Start with good news. We are on time. In Portugal, this is not as often as you used to think, by the way. So we are starting block number 3, dedicated to peripheral mechanisms of post-exertional impairment, crashing after, I like the word crashing, by the way, crashing after effort, muscle dysfunction, and exertional physiology in MI-CFS and long COVID. And the first speaker, I'm sorry, is Professor Rob Wüst. Professor Rob Wüst, thank you very much for coming to Porto. Professor Rob Wüst is assistant professor at the Department of Human Movement Sciences at VU University, Amsterdam, a fantastic city, by the way. And he is going to talk about microvascular and mitochondrial abnormalities in skeletal muscle in MI, SFC, and long COVID. Thank you for coming. It's all yours.
Muito obrigado. Eu prometi a minha mulher portuguesa que começa em português. Oi? Oh, no, wait, no, espera. Oh, this one. Espera. Vou falar sobre as anomalias microvasculares e mitocondriais no músculo esquelético, no EM e na COVID longa. Vou falar continuo in English. This is an image that we made recently that illustrates the problems that people with long COVID and ME going through when they are going through physical exertion, brain fog, changes in muscle pain and fatigue are worsening, and other symptoms worsen too. So this is going to be the main topic of today's talk. I don't have to talk you through a lot of the symptoms and the hypotheses that underlie long COVID and ME/CFS, but I just want to highlight some of the work that we did in this field, particularly because we're interested as skeletal muscle physiologists in changes, particularly here at the limited exercise capacity and post-exertional malaise in patients. We don't know the reasons for it. We have various hypotheses that have been put out in the literature, including autonomous nervous dysfunction in the immune system, of course, that is dysregulated. Blood clotting, as Professor Pretorius already mentioned, may contribute. But also, we are, as skeletal muscle physiologists, we are looking specifically at the skeletal muscle system. So to summarize roughly what post-exertional malaise is, or PEM, it's the worsening of general symptoms, or actually the development of new symptoms, typically within 2 days after physical, cognitive, or mental exertion. The threshold for patients is typically patient-specific and can vary over time. We don't know the threshold, but I'll go to what we're working a little bit on this. I'll focus on one slide in my presentation on maybe finding the threshold or finding the risk area. We don't know the threshold, but we do know that the post-exertional malaise can last for days, weeks, or even months, or can even set back patients continuously. We do know it's a cardinal symptom of both long COVID and ME/CFS, and likely also other post-acute infectious diseases. So there's a commonality in the pathophysiology that we think is really important to get a better understanding about, because that may give us a better understanding about the disease itself. Important factor to remember is that patients tell us that PEM comes with different flavors. So some people have more problems with physical PEM, others have more with cognitive exertion. And that's really not really a good diagnostic criterion. So we're working with a group in Vienna to see whether we can get better ideas about these different flavors of the PEM and what is the underlying mechanism essentially that drives these changes. So one important thing to remember for clinicians is that if you see patients in your clinic, they may look perfectly fine when they sit in front of you. They may act perfectly okay. They may speak fine. You don't see anything. They don't have any problems. That's often the reason why these people are sent back home with, we can't find a problem, we don't know why you're sick. But actually, as a clinician, I really would stress for clinicians to look the day after, because particularly the day after, patients can be really feeling ill, can be more homebound, sitting in rooms with the curtains closed to really get rid of all visual or sensory input. So it's really important to look particularly at the days when people are feeling ill, because that really brings up the disease. But as an exercise physiologist, I'm most interested in what happens in the body. We don't see patients ourselves, but we wanted to understand better the physical changes that happen in the patients with the induction of post-exertional malaise. So my next speaker today is going to talk about a 2D exercise test. We didn't use that particular method. We wanted to opt for a 2D biopsy, skeletal muscle biopsy test. So what we did is we took a skeletal muscle biopsy of 25 patients with long COVID. Now also we have 26 patients with ME/CFS and 30 controls, 7 days before asking them to undergo a cardiopulmonary exercise test. We do that test for two reasons. We do that to induce post-exertional malaise, but also to test their body exercise tolerance and exercise capacity, so that we can see what is limited, what is changing with what is underlying the limited exercise capacity, and what changes with the PEM induction. Because the day after, we asked them patients back into the hospital, and we took another muscle biopsy from the vastus lateralis, and we took blood and also biopsies. So the publication that we published on this has attracted a lot of attention a year and a half ago, including a lot of letters sent to the editor about this particular paper, because we got criticized extensively for some aspects that I'll try to now rebut in the next 10 minutes. I will not talk a lot about this paper because it got so much attention that we want to continue essentially with showing the newest data in the group. But just to get you on the same page, this is the one-page summary of this particular paper, because we found essentially contributions to the reduced exercise capacity in patients with long COVID. That included the fact that the mitochondrial function was reduced. We saw more metabolites that relate to fatigue, more glycolytic fibers, and they don't change when you induce PEM. They are really like structural changes in the skeletal muscle. However, the changes that we think are related to the post-exertional malaise induction are really rapid changes of local and systemic metabolism. But we also spotted that markers for inflammatory inflammation and markers for muscle damage were increased upon the induction of post-exertional malaise. We also spotted this amyloid-like structures into skeletal muscle that Reza Pretorius was talking about earlier, and we're now finding out there's a poster outside that we think we now know what these amyloid-like structures are. Importantly, it's to realize for patients that this work also has some practical implications. So we got a lot of questions, so I should really stop doing any exercise. Now that's not actually the case. We don't show that any exercise is better, we only show that exercise above this PEM threshold causes these things. So what patients are always advised by the clinicians that know about the disease, that pacing is important. So patients are encouraged to exercise below this particular threshold, and specifically the thresholds that do not lead to PEM. So using your watches, using variables, we think that heart rate variability may be one of those factors that can track your activity over time, where you can see whether you don't go over this particular threshold. And a student, a recent student of me, the paper is currently under review, but there's also at a preprint as well. We studied whether the heart rate variability is a useful marker to help patients with deciding to which intensities are safe. And what we think now is that around the ventilatory threshold 1 or the gas exchange threshold, that's a moment essentially where something in the body changes that induces this post-exertional malaise. We don't exactly know what it is, because also cognitive and mental exertion can induce PEM. So we think there's something happening around that threshold that increases the risk to become where PEM can be implemented or can be started essentially. And what we saw on the image on the right-hand side is that in the white circles, the healthy controls, they increased their heart rate variability very rapidly, relatively rapidly upon exercise above this threshold, close to this threshold. But patients that are mild and moderately affected, they had a very longer duration of the recovery period. And some very severe patients did not even increase their heart rate variability to levels similar to the controls. So we think that maybe that's a good way for practical implications of PEM induction and avoiding PEM induction. But let's go back a little bit and talk about the different hypotheses that underlie these changes that we see in the skeletal muscle. This is a recent paper that Braden in the back and actually all the other people, all the other students are sitting in the back, so well done, guys. They worked on. We summarized the literature and came up with different hypotheses that can underlie the change that we see in the skeletal muscle. Local hypoxia may be one, ischemia perfusion, as I mentioned before, what Professor Pretorius mentioned before. I'll go into this later today as well, is one of them. Deconditioning, people are just lazy, they're not doing anything, so that's been a major accusation of our work. I will try to rebut it in the next slide. And the electrophysiological changes are changes in the calcium, sodium channels in the skeletal muscle. I underline this is work that has been done in particularly in Germany. And we also may think that autoimmunity play a role, but we don't know so much about it. So we really want to work more on this particular aspect too in the future. One aspect that should be not forgotten is that also central fatigue plays a role. And this is not the same as that I just don't want to contract my muscles and I just don't want to exercise. It's something else. It can well be that there are changes happening in the brain that affect the excitability of the neurons to the skeletal muscle. And there's a real physiological reason why you do not or cannot contract your skeletal muscles to the same extent as a healthy control. So what is this deconditioning thing? And that was super good coincidence essentially that Braden and another PhD student in our lab, Moritz, was sitting right next to each other, where Braden did the exercise testing with the long COVID patients, and Moritz did a study on bed rest. So it was super simple to say, look, guys, you just need to collaborate now and work together and solve this problem where people are accusing us that deconditioning causes all the problems that we see in our skeletal muscle. So this is the preprint that was published early this year and is now under review. And we're very grateful that we got some really nice feedback from people. So just to give you a bit of an understanding what is a bed rest study, this is a study that was sponsored by ESA and NASA just before the COVID hit, actually. It's done in Germany in a specific setting where healthy people, healthy normal people, voluntarily lay in bed for 60 days. Everything had to be done horizontal. Brushing your teeth, washing, go to the toilet, everything was horizontal. And what we did in those particular participants, we took muscle biopsies before and after 6 days and after 55 days. So that's a completely different project in our lab. But because we knew what happens after 55 days of laying in bed, we could compare the groups. So here in figure A, you see the bed rest study where we did skeletal muscle biopsies before and after 55 days of bed rest. And there was a longitudinal cohort. And we had the 3 cohorts, the controls, the long COVIDs, and the ME/CFS patients as a comparison. If the longitudinal changes that we see with bed rest are similar as what we see in the patients, then we say maybe they can be one-to-one related. If not, then there's something else going on. So what we did is that we looked at the VO2 max, the maximum oxygen uptake consumption of patients before and after bed, and also before and after bed rest. And the figures are very similar in the sense we're in the black and white. On the left-hand side are the before and after bed rest, and then on the right-hand side are the patient populations. And you see that both of them are similar, both interventions essentially, or both conditions are similarly reduced. The gas exchange threshold is slightly different. The effects are slightly different, but technically from the outside you can say, well, something the same is happening in both conditions, so it's all to do with the conditioning. Now that's actually not the case, of course, because we looked into more detail and we also knew that this was not the case. Because if you look at markers for mitochondrial function, they were quickly reduced upon bed rest. Bed rest reduced mitochondrial function and mitochondrial density equally. But we saw that particularly in the long COVID patients, the mitochondria were there, but they did not function well. And if we correlated these two together on the bottom line, you see that the SDH activity, which is a marker for mitochondrial density, correlated very nicely in the bed rest participants, and in the healthy controls, but did not correlate at all in the patients with long COVID and ME/CFS. I don't have a pointer here, but you can see in the figure C on the right-hand side, the colored circles do not show any correlation between X and Y. And the same happened if we would use a different marker for mitochondrial respiration, mitochondrial function on the figures that you see in D. Similarly, bed rest, there was a nice correlation between the two markers, but no such correlation in both the patient populations. So really they're differently affected. And if we zoomed in, this is the work that Jelle does in our lab, looking into the electron microscopy, and we see really big abnormalities with the cristae, with the functional units essentially of mitochondria, in particular long COVID, but also we see that same thing happening with ME/CFS. So you see on the right-hand side a mitochondrial that's completely devoid of these cristae, which is really important for producing the energy in skeletal muscle. And this, of course, we did not see after bed rest whatsoever. Now we're changing topics a little bit because we had no clue why these changes that we see in the mitochondria are happening. And one of them could be because there is a problem with the microvascular function. And this here comes the Fick principle, and I'm pretty sure that that Professor Sistrom will talk about this too later on today. But we just to go a little bit quicker into this, we expected that there was a problem in the periphery and not so much in the direct heart rate or stroke volume part of the equation. And we of course couldn't measure this atrial venous oxygen differences. That's something that you would have to do an invasive CPAP for. But we could at least identify that maybe something peripherally is happening here. And this is what we did. So these are measurements of the capillary density, capillary markers in long COVID and ME/CFS. And we see that the capillary to fiber ratio, the capillary supply to the skeletal muscle, was only negatively affected in patients with ME/CFS and not so much with long COVID. By the way, these changes do happen extensively with bed rest, but I'll not show you these ones here today. Now, something that Anouk, who's also sitting in the back here, really noticed at some point during her internship. She said, well, there's something strange happening with these stainings that we got back from our pathology department about the collagen stainings, which we initially sort of discarded because they didn't show the things that we sort of were interested in. She said, look, there's something happening in these sections, because in the top right, you see a healthy control. You see for every circle of like a red dot, you see a white little point inside, the lumen of every capillary. But if you look at the patients with long COVID and ME/CFS further down, we did not pick up this particular white dot in the middle. The lumen size was really reduced. So she spent a lot of time, and I thank you very much, Anouk, for doing this work, because this has really changed our understanding of the underlying reasons why we see these changes. Is that the basal membrane thickness, or the thickness essentially of the capillary, was significantly and highly significantly different between the patients and the controls. There was no difference, by the way, between long COVID and ME/CFS. But then if you looked at the radius, the lumen size essentially of that white dot in the middle of the capillary, there was a complete separation between the groups. Everything above a value of 1.35 was we regarded as a control participant. You're in the middle image. And anything below 1.35 was a patient. There was a complete separation between the groups. And interestingly, particularly in the patients, but not in the controls, the amount of the capillaries versus the lumen size, so the potential essentially for oxygen and delivery or nutrient delivery, correlated relatively perfectly with the peak power output that they attained on the bike. So a non-invasive marker for the excess capacity, related perfectly with this particular marker for microvascular flow. So we're diving into this more, and we really think that the gas diffusion essentially is really the problem here. Now, because both Anouk and Jelle both worked on the same projects, Jelle started looking into the endothelial cells abnormalities, because we could measure them as well with our electron microscopy. And on the bottom, you see 4 images of healthy capillaries. You see a nice lining with an endothelial layer around there, which is thin, which is relatively round, is not so much problematic. But on the top right, you see an image from a capillary of long COVID patients, and it's really swollen, it's big, it has lots of different things. So let's zoom into this a little bit. So you see that the endothelial cells are really activated, and they're really actually expressing lots of these small vesicles. And we see this throughout different types of patients, and we're currently analyzing all this data. But what you see is that there are vesicles that excrete things into the circulation from these endothelial cells. And there are some other markers that also we think are related to an endotheliopathy. And of course, the thickening of this wall essentially from the endothelials to the outside is really is also important to realize. This basal membrane thickness really reduces the capacity for oxygen flow across the endothelial layer and the basal membrane layer. So we do see changes, similar changes happening in our histology sections, which really cost you maybe 10 cents in the pathology department, and this endothelial markers on the high-end microscopy level. So I think microvascular dysfunction plays a big role in long COVID and ME/CFS. The reduced lumen space, I've just mentioned before, endothelial activation and dysfunction, and then Anouk's poster showed some more additional images, additional information about this project. And we do really think that it reduces the metabolite removal, but also oxygen and nutrient delivery, predisposes patients to more fatigue. And of course, what we really want to do is, because we're thinking that maybe this is a diagnostic marker or a confirmation diagnostic marker, we're looking for independent validation cohorts, maybe not only skeletal muscle, but also skin biopsies where we could measure something similar. So I really would be interested to talk to you afterwards. One of the last things that I want to mention here is one of the things that came out of our work is a phase 2 trial that will start soon, where we collaborate with a mitochondrial company in the Netherlands called Condrion, where we are going to give patients a particular drug that has been developed for patients with genetic metabolic diseases. And maybe protecting the mitochondria from becoming damaged, we can improve the excess capacity, reduce their fatigability, and increase eventually the PEM threshold. That's, I think, our final goal, is we want to increase the PEM threshold and shorten the PEM duration, eventually also improving quality of life. So the take-home messages for today are that the patients with long COVID and ME/CFS suffer from post-exertional malaise. Mitochondrial abnormalities have been extensively described with patients. We also see it in the skeletal muscle. We don't know the X factor that causes PEM, but we do see that there can be different from the contributing factors to the reduced excess capacity. We really are confident that the skeletal muscle alterations that we see are different from those after strict bed rest, and that microvascular adaptations may be valuable, like confirmation diagnostics for the disease, and also in further understanding the pathophysiology. And with that, I would like to thank the collaborators, particularly Braden, Jelle, Anouk and Koen, who are sitting in the back. Without you, I would not be able to stand here. Patients, participants, and also all our reviewers of grants and publications. Has really been a great work, and I think it's getting time for lunch, but obrigado.
Stay here, stay here. No, stay with me. We have 5 minutes to lunch, so I think we can use these 5 minutes to ask some burning questions. I forgot to introduce myself. I'm Filipe Frois. I'm Portuguese. I'm a clinician. I'm a pulmonologist and intensive care physician. I don't work in Porto, by the way. I work in Lisbon. And I see one question from the floor.
Hi, Rob. Thank you so much for your lovely presentation. My name is Joanna. I am a colleague, a doctor, but also the partner of a person with long COVID. My question goes to you about the heart rate that you measured, which seems to be lower, if I understand correctly, in long COVID and ME/CSF patients as a response to exercise, which goes a little bit against, if I'm right, and if I understood well.
Let's explain it first, because I think it's helpful to get the image back up. This one here.
That one.
So it's not the heart rate itself, it's a heart rate variability. So the variability between every heart rate.
Right. Okay.
So that is really lower. What we typically see is the heart rate is either the same or a bit higher in patients with long COVID. This is only done in patients with long COVID that have been referred to a sports physician. So this is an observational retrospective study, essentially.
Yeah.
So we have no clue essentially what they exactly did, but what we see is that when the heart rate goes over a certain value, we know that they are going into the anaerobic area, or close to the anaerobic area, switch to thresholds. And then we don't see the same recovery essentially over the time of 24 hours.
Okay, that makes more sense, because I think Joanna Squires yesterday, a colleague from Boston, presented,
Exactly.
an increased heart rate and IC-PET. So
yeah, but this is completely different. This is wearables.
For the clarification.
Yeah, but there's also a preprint that you can read the whole paper.
We still have 3 minutes. If nobody asks, I will ask. I'm a clinician. I see patients. You have a question over there? Okay, carry on. I'm a clinician. I see patients. I have a lot of work. Most of the times we don't have time to research. So we listen to the complaints of the patients. How did you stratify the severity of long COVID patients? Did you use, for example, patients with higher infection in beginning, hospital admissions, ICU admissions, more symptoms, more age? How did you stratify?
I think this is a very important question. So there are two ways to look at this. So for the studies that we did our muscle biopsies on, they're all mild patients that are able to come to the hospital for work. They have none of them have been admitted to the hospital during the acute phase. So they all had a mild infection, and then the long COVID symptoms developed afterwards. Based on questionnaires, there you can do various questionnaires. To the FunCap is a very good one, I think, where you can stratify patients based on severity. However, on the image that you see on the slide here, the patients were classified based on mild, moderate, based on the oxygen consumption at the ventilatory threshold, which is what you can do on daily life activity. So the moderate patients here had an excess capacity, so to say, where it was already limiting daily life activity. That's what we call them, the moderate severe patients in the image on the slide here. Short question, maybe.
A very short question now. 2 minutes.
Short question. For non-doctors, and people that are watching that are also not doctors, if you'd find a way to protect the mitochondria, how long would it take for them to self-replace? What timeline would we be looking at
Short but difficult.
Short but difficult question. The trial. I'll answer it in two sides. So the drug has been used in genetic metabolic diseases where they see an improvement in quality of life after a treatment of 15 weeks. We don't know whether that's enough to change the mitochondrial biogenesis and turnover rate, but we know from the exercise physiology field that can be faster. However, with a drug, we would. So I wouldn't expect that I think the turnover rate is faster than 15 weeks for sure. 15 weeks. So the drug duration is 15 weeks. Does that answer your question? Maybe, yeah.
It does, but we need to get to why they're getting damaged so they don't self-repeat. Or can the patients be on that drug on a continuous basis to have at least an improvement on the quality of life?
Yeah, so they will. Bad mitochondria will typically always get renewed, and we don't think that specifically affected too much. I'm saying too much now because we have some recent data that may change the idea a little bit. That the turnover rates, but it's more the damage that we have tried to avoid with this particular drug.
No, it's lunchtime, but I know some Dutch words. Dank wel.
Thank you.
Thank you.